Welcome to this session about timing and indication for PCI in TAVI patients with coronary artery disease. My name is Nicolas Dumontet, interventional cardiologist in Toulouse, and I'm happy to discuss about this topic with Simon Redwood from St. Thomas, London, and Marco Barbanti from Catania. So Simon, the first thing I would like to cover and we would like to discuss is what do we do when we find some significant coronary artery disease in a patient that is about to undergo a TAVI? And I would be interested to know about your decision-making process in that situation.
Yes, thank you very much, Nicholas. And it's an important point because if somebody has coronary disease and aortic stenosis and is undergoing surgical AVR, they will almost inevitably have their coronaries revascularized. But that doesn't seem to be the case with TAVI. And it seems that it's done on an ad hoc basis. I think we're probably all agreed that if a patient has significant angina, then they probably should have revascularization as well. But in my mind, the real question is what we do with patients without angina. And for that reason, we performed the activation trial, which is actually the only randomized trial addressing this situation. So we took 235 patients that had significant coronary disease and associated aortic stenosis and were undergoing TAVI. And importantly, we took patients that had CCS class 0 to 2, and they were randomized to pre-TAVI PCI versus no pre-TAVI PCI. The mean age of the patients was just under 84, and you'll see the logistic Euroscore is 15.1 with an STS of 6.8. And what we found on the right-hand side is that if we look at the 1-year cumulative risk of death or rehospitalization, there was actually no difference between the two groups. This was a non-inferiority trial, and although there was no difference in the numbers, it did not quite reach the non-inferiority margin, and we got a p-value of 0.067. However, if you look at the as-treated population, it was significant. So I think there's fairly good evidence now that pre-TAVI PCI is not necessary. And importantly, we also showed higher bleeding in the pre-TAVI PCI group, although there was a slightly higher number of patients on anticoagulation in the TAVI group. So what I take home from this is if the patient has significant angina, they probably should have pre-TAVI PCI. If they don't have significant angina, then we should just treat the aortic stenosis and then address the coronaries post-TAVI if necessary.
Thank you very much, Simon. Very helpful. Just maybe one precision that could be useful also for us in our everyday practice. From the conclusions we can have from the activation trial, the patients who had left main or severe ostial coronary artery disease were also included. So can we extend the conclusion of activation to those patients or not?
Yeah, that's a very important point. The simple answer is no, they were not included. So if it was felt that the patient had prognostically significant coronary artery disease, they were not included in the trial. So left main or left main equivalent did not go into this trial. So I think in those patients, even in the absence of angina, we should seriously consider performing pre-TAVI PCI.
Thank you very much, very clear.
So we've heard about what we should do pre-TAVI, but how about the clinical evidence on post-TAVI PCI? And I'd like to ask Marco Barbanti what his views are on that. Marco.
Yeah, Simon, this is a very important question. And actually, before talking about what about the PCI after TAVI, we should talk about the clinical presentation of coronary artery disease after TAVI. We might say that in the last few years, we had a significant number of papers on this topic. And this is one of the most important ones published by Mantias in JACC Intervention back in 2020. And on more than 100,000 patients with TAVI, we had more than 6,000 who were admitted with a diagnosis of acute coronary syndrome, and 48% of patient of admission occurring within 6 months. And what this paper says, which is very important, that is very important the presentation, the clinical presentation of coronary artery disease. And we see here from these Kaplan-Meier curves that STEMI and non-STEMI were associated with a significant poorer prognosis as compared with unstable angina. Another paper which is very important is not just shows that not just the clinical presentation, but also whether or not this patient with acute coronary syndrome of the TAVI were treated or not. So it's very important to see that a patient who underwent revascularization had a better prognosis compared with patient who had no revascularization. And this study from Farouk's in which the management was invasive in 163 patients, and PCI was performed in 97 patients. One of the most important outcomes were that coronary access issues were assessed in only 2.5% of patients of coronary angiography and 2.1% of PCI. But more importantly, revascularization of acute coronary syndrome time was associated with a reduction of the risk of all-cause death. This is the most recent paper in Press in JACC, focusing all in STEMI patients. And it's very important to see that the incidence of STEMI was not very high, only 0.3%. But when comparing STEMI patients in those who received a TAVI as compared with those who didn't have a TAVI, the door-to-balloon time was significantly less in patients with no TAVI. The PCI failure was fourfold higher in patients who underwent TAVI as compared with no TAVI. And the prognosis of these patients was absolutely poor, with a 33% of mortality at 1 year. But regarding the feasibility of access after transcatheter valve implantation, this is a study published by our group showing that the unsuccessful coronary cannulation after TAVI was reported in 7.7% of patients. But more importantly, we were able to identify several risk factors for this important endpoint. And among them, among all, the oversizing of the sinus of Valsalva compared with the prosthesis we implanted, the size of prosthesis we implanted, the depth of implantation and the use of evolute valve were associated with an increased risk of coronary cannulation and success. But more importantly, going to the focus of PCI after TAVI, this is a study by Stefanini published in JACC Intervention this year. Is a retrospective multi-center study, including 133 patients out of more than 5,000 patients at a median time of 191 days, with a cumulative incidence of 0.9%. And we see here that PCI indication were almost equally distributed between chronic coronary syndrome and acute coronary syndrome, being non-STEMI the more important and more representative one. We saw that the PCI success was achieved in 96% of patients, with no significant difference between balloon expandable valve and sex expanding valve. So just a numerical difference, but it was not significant. And on the graph here on the right side on the screen, inside the screen, we see that all the chronic coronary events were concentrated in the first 12 months after TAVI. So this is another important piece of evidence in this topic.
Thank you very much, Marco. That's very clear. Just one quick question. You in the STEMI patients, you showed a fourfold higher failure rate. Was that due to access in patients who had previous TAVI?
Yeah, this was actually in terms of reaccess. There was a very few patients in which it was not able to, the access was obtained, but was not able to implant the stent, so to perform the PCI, but most of them were because there were some issues in the coronary access.
Right. So access is an important issue. Thank you.
Okay, so I didn't see this bounce of evidence. I would like to ask Nicholas regarding the PCI after TAVI. So what your experience? Do you have for us some tips and tricks to try to optimize our results in case of PCI after TAVI?
Yeah, thanks, Marco. As we saw during your slides and your presentation, reaccess can be a technical issue, and mainly with a long frame transcatheter head valve. And I would probably summarize the technical advices in this slide. Of course, you have to know a little bit of the core valve evolute design. It seems obvious for TAVI implanters, but some PCI after TAVI are performed by operators that are not familiar with TAVI implantation. So they just have to understand that the leaflets are mounted in a supraannular fashion, that there is an inflow pericardial skirt that can be inside the Valsalva sinus. And by just doing an angio root shot, sometimes it's useful to understand how it was implanted in the aortic root. Was it high? Was it low? You have a first understanding of the coronary takeoff. After that, my advice most of the time, even for diagnostic angiogram, is to use guiding catheter, because you have a quality of injection that is better, especially if you're non-selective. You can work with a wire inside that helps you to position. So I think it's useful advice. And most of the time you downsize the shape of the catheter you would use by 0.5, because the route in which you work with this frame is smaller. So you don't have to, you don't need to have this kind of long shape guiding catheter. And I think maybe regarding PCI, the most important advice I would give is this one, is don't lose time and energy to try to engage selectively the coronary ostia if it's not easily feasible. You can just position your guiding catheter in front of the ostia, and if you're not selective and you have to do a PCI, you advance your wire in the coronary artery, and then on your wire, you will advance a guiding catheter extension and will have all the support and all what is necessary to perform your PCI, even if it's complex. But I think it's worth considering that, and this issue of difficulties to reaccess also reflect on how to prevent those difficulties. And you all know that the idea of aligning the commissures of a transcatheter head valve has been developed in order to try to avoid to have the posts of the transcatheter head valve in front of the coronary arteries. And it's perfectly illustrated by the two diagrams you have on your screen. On the left, a good orientation. On the right, a bad commissural alignment, making some difficulties to reaccess the coronary arteries. So for the Evolut frame, we know that we can have an anticipated good, proper commissural alignment by just at the time of the introduction, putting the delivery catheter in the position you have at the left of this slide with the flush port at 3 o'clock. And it's something that it's possible also to validate once inside the aortic roots. Looking at the right of this slide, you see that you have a heart marker at the distal tip of the Evolut frame. When you work in LAO or freecast view, if you have this heart marker at the outer curve, you will probably have a good commissural alignment. If you work in cusp overlap view, it will have to be in the center front. And once the valve will be released, look at the left now of this slide, you will have a C-tab at the outflow portion of the frame that will be located at the inner curve in LAO, ensuring that you will have a proper commissural alignment.
So thank you very much, Marco and Nicholas. We've had an interesting discussion about the role of pre-TAVI PCI, the fact that post-TAVI PCI, we do see acute coronary syndromes in just under 5%. Thankfully, STEMI is very uncommon at 0.3%, but access issues are important. And Nicholas very elegantly summarized tips and tricks for post-TAVI PCI, and importantly, the importance of commissural alignment, which is actually very easy with the Evolut valve by just making the flush port at 3 o'clock. So thank you very much, Marco and Nicholas, and thank you very much, EuroPCR, for this invitation.